to our Kansas City Quality and Value Innovation Consortium Forum. Our vision is to bring multiple stakeholders together to improve the quality and value of healthcare. KCQVIC is supported by our partners BioNexus KC, UMKC NextGen, and KU Frontiers Clinical and Translational Science Institute. My name is Christina Pacheco, and I will be your moderator for today. I am an implementation manager with KC Quality and Value Innovation Consortium. We need to find ways to deliver better care at lower cost to achieve better health for patients and populations here in Kansas City and in the region. To do that, the Kansas City QVIC has created several different activities, and to date they have centered around 3 specific activities. First is area focused on our regional quality improvement projects. We've got 2 projects, and those are KC EPIC, our opioid project, in which we have 8 participating hospitals, and second is our Transitions of Care for Heart Failure project. This project focuses on addressing social determinants of health, and we have 11 hospitals expressed interest in participating in that project. In addition to these regional quality improvement projects, we're also helping to implement and evaluate the success of these projects. We've developed a training and implementation actionable research approaches. We educate investigators, quality improvement personnel, and others about implementation and methods behind implementation. We are currently working on revamping this into a formal coursework. And then finally, why we're all here today, the Kansas City QVIC Forum, which is a strategy for engaging communities and stakeholders through the dissemination of information that is important to you and provided by members of our community. This shows an overview of our remaining forums for the year. Next month, we will be discussing an update from our opioid project, and that will be on July 15th from 3 to 4:30. Here is a look at our agenda for today. We've got an excellent lineup of speakers. And before we get started, we'll touch just a little bit on the theme of this forum. So we're looking at trauma-informed care and adverse childhood experiences. Trauma occurs when a person exposed to an event or a situation that overwhelm their ability to cope with what they have just experienced. It could be a single event, a series of events, or a chronic condition. And this experience is individualized. Just because an event causes trauma in one person, it doesn't mean it will necessarily cause trauma in another, and vice versa. In 1995 to 1997, there was a study conducted at Kaiser Permanente on adverse childhood experiences. There were 2 waves of data collection, and the researchers studied relationships between child physical abuse, child sexual abuse, child emotional abuse, emotional neglect, physical neglect, mentally ill, depressed, or suicidal persons in the home, drug addicted or alcoholic family members, witnessing domestic violence against the mother, loss of a parent to death or abandonment by parental divorce, incarceration of a family member for a crime. The study found that these experiences have profound impact on health outcomes later in life. And the study has been replicated in other populations and also found to have very significant impacts on health. Researchers are also finding similar correlations between these adverse experiences and long-term health outcomes: racism, poverty, systematic oppression, exposure to community violence, microaggressions, stereotype threat, and overly punitive school discipline. We welcome Dr. Carmen Alvarez from Johns Hopkins University School of Nursing, who will be sharing a research perspective on why ACEs matter for healthcare. Welcome, Dr. Alvarez. Is she frozen?
Can everyone hear me okay?
Yes. While we are working on technical difficulties with Dr. Alvarez, let's move to Leah Miller, the Associate Director at the Jewish Federation of North America, who will be sharing a federal nonprofit perspective on person-centered trauma-informed care for older adults with a history of trauma. Thank you, Leah. Oh, you're muted.
Sorry about that. It's a pleasure to see all of you. Can you hear me now?
Yeah, thank you.
Great, great. I'm sorry that my colleague didn't get to go first because really having a background in the ACE study would be very helpful. So we'll definitely go back to that. So my name again is Leah Miller, and I am the Associate Director at the Jewish Federations of North America's Center on Aging and Trauma. And so really what we focus on is older adults and trauma. And the ACEs study really is talking more about children, as you'll hear later. So with that, what I'm going to cover today is what the impact of trauma is on older adults and how to understand the person-centered trauma-informed care approach and how it can be implemented. So if trauma is the problem, this is the solution. And also learn how a national nonprofit organization builds the capacity of aging service providers to provide person-centered trauma-informed care. So, sorry, my slides are going crazy. So I was wondering, how many of you would have anticipated that 90% of older adults have had a history of trauma in their lifetime? That's really the vast majority of people. And so that's something to be mindful of when you're working with any older adult, is really that you provide consistent person-centered trauma-informed care to all. Oh, goodness. There are individuals' trauma exposure is linked to their propensity, sorry, I don't know what's happening with my slides, to developing a wide range of conditions that negatively impact their physical, mental, and cognitive health. And some of the things I want to bring to your attention that you may not have expected is trauma is linked to increased rates of lung disease, gum disease, gastrointestinal issues, reproductive disorders. I think many people might have anticipated the anxiety and depression, but I don't know if you all would have thought about dementia or sleep disorders or cognitive impairments are also closely linked to having a history of trauma. And so trauma impacts people differently as they age. It could be that somebody might have really gotten to deal with their trauma at one point in their life, and then now as they get older, it reemerges in a different way. And so symptoms can evolve after a long time of being symptom-free, or it could be that they could emerge for the first time as an older adult as certain triggers appear. Also, it can be more extreme than it used to be. I'm sure many of you might have met an older adult where they constantly go back to that place of trauma, and that's a loop that they get stuck on. So it can be that somebody might have had it in a nice little box, and it starts unraveling as maybe their role in their family changes. Maybe they were the decision maker, or maybe they were the family caregiver, and now all of a sudden someone is caring for them and they may not have as much decision-making power. Or maybe if they're like me, where you define yourself by your career, that retirement can really be a trigger as your whole lifestyle changes. Or as you've relied on certain strengths that you have, like maybe you have really good hearing or good sight. And as you get older, as you start having medical impairments, you may not feel as safe. So think about a survivor of domestic violence, or to have the strength, or to be able to run, or those kinds of things. And certainly losing independence or losing control can certainly be a trigger. And relying on others. or loss of loved ones, it might completely change the financial status of a home or change your coping mechanisms. Like I'm a big walker, or I like to take a hot bath. And maybe those things are not options, or my husband likes to take a drive. Maybe those aren't options as you get older. So I'd like you to put in the chat box. We at the Center on Aging and Trauma started working with Holocaust survivors before. Now we work with all older adults with a history of trauma. But these are just some of the triggers that we have seen. And so a trigger is, it could be a sound, a smell, a touch, a sight, a taste or feeling that brings you back to that trauma that you may have had. So if you can think of, this is with working with Holocaust survivors, white coats are a trigger because of the medical experiments, or the smell of bleach, because that might have been all around them, or needles from tattoos is another thing. If you can put in the chat box triggers of populations of older adults that you work with, that would be really interesting to see of different things. Great. The next one is, so now that you are aware of these issues, what is the response? And the response is person-centered trauma-informed care, which is a holistic service approach, a holistic service delivery that promotes trust and dignity and strength and empowerment of all individuals by incorporating the knowledge about trauma into agencies' programs, policies, and procedures. So what this means is being aware of, let's say with staff, aware of secondary trauma or an agency space. Does the artwork on the walls reflect the clientele that you're serving? And this is based off of SAMHSA's principles of trauma-informed care. And I'm not going to go too far into this, but I just want to highlight a few. Safety and trustworthiness are key. And sometimes you might think that somebody's being incompliant. It may just be an issue of not feeling safe or not feeling not trusting. So one way to go about it is to give as many choices as you possibly can so that people can voice their opinion. So here's an example. In my beloved city of Washington, D.C., this was the sign that you used to see of where to go to get treatment for, let's say, detoxification services. Now, really, is that the direction you're going to want to go in? Oh, and yes, there's also STIs in that direction. No, that's not the direction you want to go in. Whereas I went to a museum, and here's an example of something that was very trauma-informed, that it was a history study. So just to let you know that this is what to be prepared for. So as I said, I work at the Center on Aging and Trauma, and our main mission is to increase the nation's capacity to provide person-centered trauma-informed care. And in Washington, we have an abbreviation for everything, so we're going to call it PCTI from here out. And we really focus on helping Holocaust survivors, older adults with a history of trauma, and their family caregivers. And we do this by funding grants across the country that do the hard work of working with these different demographics to come up with innovations in person-centered trauma-informed care. And we also try to increase the knowledge and skills of service providers like you. We get our funding from the U.S. Department of Health and Human Services, Administration for Community Living, and it goes to us, and we give the funding to subgrantees. And we really provide a lot of capacity building to ensure that that our agencies are well equipped to do this. And we want to be good stewards of grant funds. We have funded hundreds of programs across the United States over the past 5 years. In fact, in 21 states, and these are the places where we have funded, just to give you a clue. So I could talk for hours about this slide of all the great programs that our agencies have come up with, but I'm just going to highlight a couple offhand. So one of our programs has trained doctors and dentists to be more trauma informed, and we have that training available if you're interested in seeing it for medical care providers, of things to look out for older adults with a history of trauma. Something else is, let's say if there's a writing therapy program, maybe to write about home and not to write about the actual trauma event. Or another thing is if somebody grew up hungry, if you go to a socialization event, to give Ziploc bags so people can leave with it so they don't feel like they have to stuff everything in their mouth and not leave any food behind. They don't want it to go to waste. So those are just a few little tips, tricks that I've learned over the years, but I could talk about this one for a while. So Christina wanted me to focus on the capacity building of what we do and the services we provide. And so one of the things that we do is individualized coaching check-in calls. And so during these calls, we figure out how we can best support our agencies. And these are quarterly calls, and find out their updates and also help them problem solve. I feel like a big part of my job is matchmaking, because while I may not know the answer, I know somebody else who does, and I try to connect them. We provide fundraising and evaluation consultations, because how can you evaluate, how can you see the progress without doing the evaluation? And these evaluations are done in a person-centered, trauma-informed way. So we don't want to ask necessarily what the trauma was and make somebody go through that again, but there's ways to ask questions in a way that may not be triggering. We also conduct site visits. Another thing is we have a resource website, which is Aging and Trauma, and I encourage you to check it out. .org. We also do training webinars like this one. And in fact, there's another one coming up just on June 23rd, where we're talking about vaccine reluctance among older adults with a history of trauma. And we have a training workshop as well. So like I said, we encourage you to check out agingandtrauma.org and participate in our webinars. You can write me at, and I'm happy to put you on our list. And also there's opportunities for grant funding in the future. And so I challenge you to figure out how you're going to make your practice more person-centered, trauma-informed.
Thank you so much, Leah. And if anyone has any questions, if you'll put them in the chat box, we do have Dr. Alvarez with us. And she is next, and she's going to be giving us the research perspective on why ACEs matter for healthcare.
Okay. Well, thank you, and good afternoon, everyone. Can you see my slide okay?
Yeah.
Great. So many of you know, as my colleagues have just shared, that many adults who have experienced some form of child maltreatment often times also experience physical and mental health problems later in life. And so my work focuses on how to best support this population, improve their well-being, given that they tend to have poorer health and health outcomes. So adverse childhood experiences, as Christina had shared earlier, refer to a wide array of experiences that occur under the age of 18, and they refer to physical, emotional, and sexual abuse, physical and emotional neglect, and household dysfunction, including living with an adult with mental illness, an adult with substance misuse, having an incarcerated relative, divorced parents, and witnessing domestic violence. Researchers have also established that ACEs are a risk factor for poorer health behaviors and poor physical and mental health. There's also a dose-response relationship where experiencing more than one form of abuse is associated with greater risk for poor health behaviors and poor health, particularly depression and anxiety. So unfortunately, ACEs are a very common problem. Over half of the US population reports experiencing at least one. Problems mainly arise in the population where they have experienced more than 4 different types of maltreatment. And my reason for focusing on this population and this issue is because of my clinical practice. I've been a family nurse practitioner for 14 years, caring for patients in primarily community health centers. And I started to notice that those who seem to struggle the most with daily life challenges and managing their chronic disease often had histories of early childhood trauma. So again, my interest is in how to best support this population. So various researchers have also proposed the different mechanisms by which ACEs negatively impacts brain and body development. So very briefly, the chronic stressful environments and the adversity impact brain development, particularly the prefrontal cortex, the amygdala, and the hippocampus. So all areas which are very important for executive functioning and emotional regulation. And that in turn impacts health behavior and health. So I'll go ahead and share some stories, or some quotes rather, from some research participants that I think demonstrate why it is so important for us providing health services to be aware of ACEs and how we deliver care to this population. So a few years ago, I had the opportunity to collaborate with Dr. Lisa Cooper on the Rich Life Project, which is a study focused on addressing disparities in hypertension. And it's a large study involving over 30 practices across Maryland and Pennsylvania, and includes some federally qualified health clinics and a private health system. And we only enrolled patients who had a diagnosis of hypertension and one other cardiovascular risk factor, such as diabetes, smoking, or high cholesterol. And we enrolled over 1,800 participants. And as part of the study, we assessed for or asked questions about adverse childhood experiences. So I was interested in how ACE survivors manage their hypertension compared to those who had not experienced any ACEs or did not report experiencing any ACEs. Again, just trying to get a better understanding of where we need to focus our attention and support for those who typically have poorer health outcomes compared to those who have not experienced ACEs. So we used the baseline data to generate a list of participants who fell into one of three categories. So people who did not experience any ACEs, those who experienced ACEs without sexual abuse, and those who had experienced ACEs with sexual abuse. And for each category, we tried to make sure that we had representation from the different community health clinics, private clinics, men and women, and some racial diversity. And these are just some of the questions that we use to facilitate our discussion. We asked participants just to tell us about themselves, when they were first diagnosed with hypertension, how they managed their hypertension then compared to now, and to describe their relationships with their healthcare providers. So here are just some characteristics of our participants. They were on average 56 years old, mostly female, white and Black, equally represented. So there were no major differences between these three groups except for depression, where ACE survivors had higher scores for depression symptoms compared to the non-ACEs group. And we conducted a thematic analysis of our transcribed interviews, and the following themes were the result. So almost all participants identified stress as a reason for their uncontrolled blood pressure. Also, most participants, regardless of ACEs, shared their challenges with lifestyle changes, mainly because of life. So work, commuting, managing family schedules, all of that, just making it hard to remain consistent with lifestyle changes for optimal blood pressure control. And I'll share just a few quotes from some of the themes in the interest of time. So attitudes about self-care refer to participants' comments about their beliefs and outlook on managing their health. So even though participants across groups, all participants across the groups were experiencing challenges with lifestyle changes, we found that many of the non-ACEs participants seem to have a more positive outlook on their challenges and believe that they could overcome them, and had some plans for how they were going to overcome these challenges compared to those who had experienced ACEs. So here we have a woman, for the quote on the left, who tries to not let anything get in the way of the physical activity that she can do, right? So as I said, even with the disability that I have, I'm trying not to let it hinder me from moving. Even with my cane, I still try to go to dance class once a week. Versus the other person who seems to have reconciled that there is but so much they can do. I'm Black and people have hypertension no matter what they do. So sort of not realizing their agency in managing their blood pressure. Coping strategies, these were participants' comments about how they minimize stress and strategies that they use to adhere to medications and lifestyle changes. And again, here you have an example of someone who takes opportunities to remain physically active despite issues with pain. So during the week, I may have to walk to go get my medicine, which gives me some exercise. Even though I can take public transportation, I try to get some exercise in because of my weight. I'm trying to lose some. Even though I'm in pain, I still walk to keep my joints from atrophying. Versus our other person who has experienced ACEs who has opted to remain out of care because she doesn't feel like going through the process of restarting medications with a new provider. So choosing avoidance rather than dealing with the issue. I'm frustrated. I know most likely they'll start at the beginning again. I don't feel like going through the side effects and all the problems that are associated with the medications. And then the experiences with healthcare. So participants' comments about experiences they had with current or past providers. Now, almost all participants, regardless of category, shared positive experiences with healthcare providers, particularly their interactions with their current providers. Good providers were consistently described as being active listeners, available to respond to requests, people who are knowledgeable and encouraging of behavior change. However, those who had negative experiences, in some cases, it was bad enough to keep them out of care or prevent them from returning to a particular provider. So in this scenario on your left, we have a patient who initially sought care for their depression. And because of what they've described here, they never attempted again to get treatment and had gone over 15 years without treatment. I don't know what he was, but somebody recommended him to me. It was the worst thing I ever did in my life. He was very abrupt. I said to him I had to go and never went back. I've never seen anybody since then. I guess I've been dealing with it in any way that I can. And another participant here consistently felt as though they were not being heard or understood. And this also contributed to their inconsistency in seeking care. I told them a million times, I feel like I'm just a sheet of glass and y'all are just looking through me. You don't hear nothing I say. So even though ACE participants had positive experiences, again, the negative experiences were enough to deter them from care, which has really negative implications for people who are dealing with an uncontrolled chronic illness. So because we were looking to compare groups, we also counted the frequency of codes by category. So for social support, these were participant comments about having family and friends with whom they had a bond and also provided for or received emotional support. And we observed more codes for social support from family among the non-ACEs group. So these non-ACE participants commented more on quality of family relationships in which they enjoyed spending time with family members and also received encouragement and instrumental support that promoted healthy behavior change. And then for attitudes about self-care, we observed more positive attitudes from the non-ACEs group, and the same for coping strategies. We observed more adaptive strategies in the non-ACEs group compared to those who had experienced ACEs. So although this was a small qualitative study, our findings reiterate the importance of considering ACEs in adults. In this case, even in the small sample of participants with uncontrolled blood pressure, those who were ACE survivors seem to have different needs for hypertension management compared to those who had not experienced ACEs, particularly identifying and managing their depression, in making sure we were creating a positive environment for patient engagement. We should be doing this for all patients, but it seems as though it's that much more important for ACE survivors. The other point I would like to make is that all participants were aware of the health behaviors that they needed to practice for optimal blood pressure control. From a practice perspective, our tendency is to want to educate people and inform them about how to better manage their condition. And our findings suggest that among survivors, uncontrolled blood pressure was not an issue of education. They knew they needed to go out and walk. They knew the foods that they should not be eating. But it was more so an issue of low psychosocial resources for addressing the stressors and the depression that was getting in the way of them practicing the lifestyle changes that they knew they needed to be practicing. So I think it's important for practices to think about how to meaningfully include ACEs in their assessment. I don't think it's something that should be included if there are no resources to be able to support the patient. Otherwise, why are you asking? But I think it is good to be aware of and to think critically about how it can be assessed and how it can be used to better support patients for improved outcomes. And those are my comments. Thank you.
Next, we're going to have Dr. Stacey Farr, who is a research assistant professor with the University of Missouri, Kansas City, and one of the leaders of KCQ-IC, lead us in a discussion and question session.
Great. Thank you, Christina. Thank you to the two speakers we've had so far. Leah and Dr. Alvarez, those were great. If anyone on the line would so like to either enter a question into the chat or would like to unmute themselves and ask a question of one of our two speakers or provide a comment, we would welcome that at this point. We have kind of two Q&A sessions in this panel, and after this one, we'll be hearing from two more of our speakers. But I'll first open it up to anyone on the line who would like to ask a question. Otherwise, I'm not seeing any directly yet in the chat, so I'd be happy. I have a couple questions of my own too.
So I do a lot of work with Indigenous populations, and while a lot of Indigenous populations do tend to have higher elements of ACEs, it's a lot of times the historical trauma too that isn't captured by ACEs, the boarding school system and things like that. How are those elements kind of accounted for when dealing with trauma? And is there a movement to capture those kinds of elements when looking at trauma?
Yes, so I have a colleague, Dr. Teresa Brockie, who is working specifically on issues of intergenerational trauma and ACEs with a Native American population. So I would, to answer your question, I think, yes, there is some movement towards trying to be a bit more expansive and comprehensive about what we mean by adverse childhood adversity. The traditional ACEs was developed with a predominantly white population. And so, yes, there's work being done with other groups to try and be a bit more comprehensive. I do quite a bit of work with Latina immigrant women. And so we've been using the ACEs International Questionnaire, which is more comprehensive. It includes questions about community violence, so witnessing community violence, also collective violence, also known as political violence. So that would include things like police brutality and bullying. So I think there is a movement now to, especially as we consider more diverse populations, to rethink what we mean by adverse childhood experiences and go beyond the traditional ACEs that are typically used. Bruce Bagley has asked the question about whether or not patient activation is correlated with ACEs. And that was one of my first hypotheses, that people who experience ACEs perhaps have lower levels of activation. And with Latina immigrant women, and also with the same Rich Life sample that I described with 1,800 participants, ACEs was not, it depends on the population. So in the general population, when you're accounting for other current stressors, ACEs is not associated with patient activation. But when you look at the two together, not controlling for other variables, there is a negative relationship between ACEs and patient activation. It's a weak one, but yes, it is there. So thank you for asking that.
Yeah, and I mean, I would be curious on some of like the, getting to action and like the clinical recommendations that kind of come from this. If the patient activation scale is maybe not necessarily a best proxy by which to capture or measure. I mean, are there certain scales or which that like in terms of recommending for clinical practice, like other than, depression screeners, as I think you had kind of mentioned, is one way? Are there other ways or strategies that we think, clinically there's a better way to capture this so that we can tailor kind of, the treatment recommendations or, their strategies for achieving better outcomes? Is there a way to capture it now that we're kind of identifying this as clearly a problem? I'd be curious to hear your words on that.
Yeah, so far, I think the traditional ACEs is what is being used. Perhaps a different tool is coming, but I think other ways I think are perhaps more indirect. And there are, of course, pros and cons with going about the issue in a more indirect way, like, tell me about what it was like growing up in your household. How were you disciplined? What is your childhood memory? Favorite childhood memory? I think there are different ways of dancing around the topic that again has its pros and cons. And yeah, I think hopefully there's some work being done on a more ideal tool for use in clinical practice once we determine how to best use it in a clinical setting. I think that's still to be determined, and how we should best respond.
Mm-hmm. Mm-hmm. And then there's another question in the chat from Jennifer Gardner. And she said on the ACEs Too High website, they share a study that was performed on resiliency and how whether or not a person has a higher resiliency and they're more capable of overcoming adverse childhood events, or whether if they're whether or not they have high resiliency, if they can overcome ACEs. And she thinks that's something important to capture when assessing. And I would be interested to hear your thoughts on resiliency as a whole and the science and how that intersects with ACEs.
That's not a particular area of mine, but a lot of people who have experienced ACEs are resilient and not experiencing any depression or chronic illness. And even if they are, they still have their own aspects of resiliency. I mean, they're here, they're thriving, they're all doing the best that they can. And I think having an understanding of their history can help us be part of their rebound. And there's another comment from Amanda. Interviews with women who have high lifetime trauma exposure, often including ACEs. When I ask what prevents keeping them from getting screened for cervical cancer, substance use often comes up. Not surprising given the role substance use can play in coping with trauma. Sadly, the substance use often puts the women in the way of further trauma. I wonder if you have found that substance use played a role in the interviews with the heart patients, and if so, what that looked like and how it might affect care for those patients. So in the participants that we interviewed, I heard of maybe 2 people who had struggled with substance misuse in the past. But they were not currently dealing with substance misuse. And it was assessed overall in the entire sample. And we did not find a lot of substance misuse in that particular sample. But I think it goes back to us being, at least from the healthcare perspective, doing adequate assessment and having appropriate referrals and support for helping patients address the substance misuse issues, and of course, getting to the underlying issues, which is often the depression or the anxiety or some other mental illness that is contributing to the substance misuse. They're all great questions.
Yeah. Anyone else have any questions for Leah or Dr. Alvarez on their presentations or actions moving forward? Say, hearing absence. If anyone wants to add any to the chat, that's certainly welcome. And otherwise, I'll turn it to Christina to introduce our next speaker.
Thank you so much, everyone.
Thank you so
Thank
much.
you.
She unfortunately has to leave early. And so if anyone has any further questions for her, they can reach out to Stacey or I, and we can connect you. Next, we will hear a healthcare perspective from Amanda Texter, who is a medical social worker in a Beacon clinic at Children's Mercy Hospital and Clinics, and she will be speaking about implementation of trauma-informed care principles in complex pediatric primary care. Welcome, Amanda.
Thank you so much. Can you guys hear me okay and see my screen?
I can hear you and see your screen.
Perfect. So like Christina said, I'm here today to talk about the clinic I work in. It is a clinic for children with medical complexity and their siblings, and how we incorporate principles of trauma-informed care. So we are going to review the population of patients that we serve within our clinic and talk about some trauma-sensitive tools and practices we use when working with patients and their families. So that was the objectives. So we have an actual trauma-informed care department at our hospital that has created curriculum other hospitals now use to be conscientious of patients' needs and how to better serve our patients and their families. So this is just kind of a picture of the trauma-informed healthcare arms of what we strive for. What we're talking about today is trauma-informed care and strategies within that model that Beacon strives to be attuned to. There are other efforts throughout the hospital to promote trauma-informed care, but I'm only speaking to Beacon Clinic today because that's what I'm most familiar with. So I really want to hone in today on awareness and sensitive practices. So first, to be aware, you have to know, who you are working with. So I'm going to go over kind of a basis of our population. And then with the sensitive practices, I love the concept of universal precaution. So just like you're putting on gloves whenever you're working with any bloodborne pathogens, you're always just assuming that people might be coming from a place of having a traumatic experience to be sensitive at all times to make it a more hospitable and welcoming environment. Also understanding that maladaptive coping strategies may be at play. I know within the hospital field, some people talk about, parents that are hard to deal with, or patients, that are non-compliant. But I love that model of not thinking about like what's wrong with you, but what has happened to you to be able to partner together to work in a productive manner. And then also that resilience at work piece, just making sure staff have awareness and support to mitigate the impacts of trauma in their own lives so that they can work at the top of their level. So talking about the Beacon patients, so this is just kind of a snapshot. Of course, every person is different, every patient is different, but in order to have criteria into the Beacon Clinic, these are some common themes you might see. So our patients are very medically complex. They often have a laundry list of medical diagnoses. As you can see, like neurodegenerative diseases, neuromuscular diseases, life-threatening conditions, just a lot of different complicating factors. Oftentimes our patients have medical technology needs like feeding tubes, G-tubes, trachs, vents, all kinds of medical equipment to help sustain life. And then they often need, support with almost all activities of daily living. It's not uncommon to be approved, but not get the home nursing hours, unfortunately at this time, but also, having various therapies and whatnot. And then also, again, every person is different. So not every patient will experience these things, but possible social concerns or ACEs, if you will, in some cases, are different situations, psychosocial barriers that families might come across. One trauma that most of our patients and families do share in our clinic is medical trauma. So some caregivers have learned of their child's needs in utero. Some didn't learn about it until birth, or maybe it was a birth injury. You know, a lot of people are wondering if their children will survive these conditions. And then others might become medically complex through accidents or neurodegenerative diagnoses that are diagnosed later in life. There's often a lot of grief that's going on of, you know, what your hopes and dreams were for your children versus what reality is now, and kind of coming to grips with that. And most all of our patients have had some kind of life-threatening event at home, you know, perhaps a scary ambulance ride, needing resuscitation, PICU admissions, that kind of thing. So that's just kind of the awareness piece of where we're trying to come at when meeting families where they're at. So some special things that we do specifically in the Beacon Clinic, and I'm sure a lot of clinics and medical settings hopefully try to strive for this, is person first language. The concept of person first language came from persons asking to be defined as persons and not their disability or diagnosis. So at Beacon, we really try to get to know your child on an individual basis. Of course, we are there to help manage the medically complex conditions, but we really want to know what the kiddos like, enjoy, what they enjoy doing, and really listening to their families' worries and concerns, partnering with the parents, and knowing that the children or the parents really truly know their children best, parents or caregivers. So as you can see, just kind of some different things of words to avoid and what you could say instead. Other things that we make sure to do, so we are a multidisciplinary team. We have doctors, nurse practitioner care coordinators, nurses, care assistants, pharmacists, psychologists. You're referred to the psychologist, so you don't automatically see that person, but you do automatically see a social worker and a dietitian. And for someone who might have had some trauma in their lives, those can be kind of questionable disciplines at times to see. Oftentimes when someone sees a social worker, they're thinking, oh my gosh, what did I do wrong? Am I in trouble? Or my kid's going to be taken away? That's just kind of, you know, the historical pattern that our profession has had in some cases. So I always like to start off visits by assuring the families that we see all families. It's not that we're singling out any families to see. We are there to really help meet the families where they're at and provide any resources or needs. And the reason we're asking personal and sensitive questions is so we can better understand their situation, to know what resources to refer to, and really asking permission before we ask personal questions, because we're really asking all about those traumatic experiences and, you know, what life is like and what your needs are. And then during the psychosocial assessment, really being attuned to those needs. So, you know, a social worker might traditionally ask, can you afford your housing? Do you have any concerns about, you know, like pests or rodents, or, you know, is your home safe? But keeping in mind our population and the awareness, we're also asking about accessibility needs. Are you able to navigate your child in and out of your home? Do you have a ramp for your home? Are the doorways wide enough? Do you need a bath chair or a ceiling lift or something like that? And trying to make sure we're asking all questions that they might need. And then with the dietitian, she has educated me that oftentimes the perception is when a dietitian comes, you're thinking, oh my gosh, they're here because they don't think my child's growing well, they're malnourished, they're gonna probably push a G-tube on me. And so really, she also tries to explain her role is working with families, not against them, and really knowing that the parents know best, and trying to give choices when you can, when she makes recommendations such as formula type, you know, feeding regimen, that kind of thing. We also have gotten rid of any developmental milestone screenings. Like, I know sometimes when you go to primary care offices, you're looking at like the ages and stages questionnaires and those kind of things to talk about typical developmental milestones, but many, if not all of our patients are not on that schedule and are not going to reach those milestones. So it's just a hurtful and painful reminder of what a child might not ever be able to accomplish. And we don't want to focus on that. We want to focus on their victories and what they are accomplishing, and any areas that parents have concerns. So in place of those developmental screenings, this is the first page of the paperwork you'll see when you come to Beacon Clinic. It just really asks parents what their concerns are today, some common paperwork that we're often filling out, and then any specific needs they might have. Another way that we try to be sensitive and use sensitive practices is when we talk about transition. So hospital-wide, that has become a very big initiative of starting to talk to patients at age 12 and every year in various clinics about what life is going to look like in the adult world, and trying to prepare families and patients to move them from pediatric care settings to adult care settings. And that can be horrifying to our families. In the Beacon Clinic, you know, they didn't even know in some cases that their child was going to survive, and they never even envisioned of, you know, how to navigate this journey moving forward. So oftentimes there are standardized questionnaires for transition that patients can fill out that ask, you know, what they can and can't do and what they're going to need help learning about. And so we've decided to skip that part and really just ask the family about their fears, concerns, needs. And then a couple of years ago, I met with Children's Mercy stakeholders like social workers in different clinic areas, parents for their feedback, the transition program manager, and the rehab medical director to brainstorm topics to give guidance on and to really talk about to field these visits. So we now have paperwork compiled to give guidance on each topic at the different stages. So on the left side of this, you can see what a child might commonly have as their transition discussion at certain ages. And then on the right-hand side is kind of what Beacon did to modify that to talk about other resources that might be more applicable for families. There's also a few guides that are used hospital-wide. So what I just spoke about was what I really know to be the case in Beacon. And then there's a few tools that we now use throughout the Children's Mercy system. So the first one is the Thrive Guide. It is a sensitive note in the electronic medical record that helps to operationalize trauma-informed care. It's a tool, it's optional for parents and patients. It's not required for every patient, but sometimes it's helpful for staff to know a little bit more about a family's history or current circumstances to fully understand what it's like for them to cope with having a sick child. So for example, I know sometimes there might be a little extra judgment or question when a family isn't at the bedside 24/7 when their child has been admitted. So maybe if somebody understood, you know, this person is working a job that doesn't offer FMLA, they know that their child is safe in this hospital, and they're really doing the best they can and going to work to avoid losing their home, or basic resources that might make someone more compassionate when parents call for a medical update. So just some examples of different situations that if the parents want to share, they can have that in the electronic medical record that's really easily accessible to anyone within the hospital system. So this is what the Thrive Guide is. It's like broken down into those 3 questions, and then there's different kind of guiding questions. So the goal of the Thrive Guide, really, we just want it to be one consistent place that staff can find valuable information that will help improve communication with the patient and family. It increases compassion and understanding for patients' experiences and circumstances. They have found that it has decreased the need for staff advocacy and behavioral plans, and really avoids re-traumatizing patients and families. Where the hope is that if you can put this in here, families don't keep having to retell their stories or feel awkward or concerned or worried during different encounters within the hospital system. So an example with relevant family history, you know, it might be something like patient had a sister that died in 2017 in the PICU. So if, you know, one of their other kids has to come to the hospital, they're cognizant of the fact that, wow, this must be a really traumatic thing to have to come back to the hospital or experience. Another one is he knows me as grandma. Please do not refer to me as foster parent. So anything that you just would rather have out there so that you don't have to keep repeating yourself. Communication tools, you know, how families prefer to have information received. I had one mom say, when I get new information, I just need a minute to process. And so please provide me with a chair to sit down to kind of collect myself, give me a drink of water, and then we can keep talking. And then communication tools, you know, so an example, in the family's culture, people are addressed by their first and last name. Please be aware and address patient as first name, last name. So those are just some examples of how the Thrive Guide could be implemented. The last one is the PAUSE program. So we had some feedback from families that helped us realize we were not adequately meeting needs of patients with sensory processing difficulties. So a task force was created, which looked at areas where we could improve upon this. And so it's really looking at areas of sensory input for patients and making a PAUSE guide similar to the Thrive guide, which is easily readily accessible in the medical record, right? When you pull the patient's information up, you know, it might say something like triggered by loud noises or lots of people in the room, keep people in the room to a minimum, you know, what they're comforted by, perhaps like a favorite toy or a weighted blanket. You know, what might it look like when a child is anxious? Perhaps for one child, they start crying, or another one, they stop talking. So just some better ways to understand what patients are going through and how to be sensitive to meet their need where they're at when they're here. We also always have Child Life as a resource that can be requested anytime to help explain any scary procedures or new situations and can aid in relaxation strategies. So that is what I had for today.
And next we have Kristen Castle, Executive Director of Hope Kids, and Andy Elliott, a Hope Kids parent, who will be providing us a community-based organization and family perspective, restoring hope to families who have a child with life-threatening medical condition. Welcome, Kristen and Andy.
Thank you. Okay, can everyone see my screen okay?
Yes.
Excellent. Well, thank you and good afternoon, everyone. I am Kristen Castle, Executive Director of Hope Kids Kansas City. And joining me today is an amazing Hope Kid parent, Andy Elliott, and she will be speaking after I go. And we're going to be talking about restoring hope to families who have a child with a life-threatening medical condition. Hope Kids and our mission is to provide ongoing events, activities, and a powerful, unique support community for families who have a child with cancer or some other life-threatening medical condition. We surround these remarkable children and their families with the message that hope is a powerful medicine. So why Hope Kids? From the diagnosis, as Amanda was speaking from the Beacon Clinic, we do have many of our family members are also part of the Beacon Clinic. So once the child receives the diagnosis, from navigating treatments to the constant fear of relapse, it's not an easy journey for anyone, let alone a child. It's not only traumatic for that child, battling a life-threatening medical illness turns the entire family's life upside down. Parents are often overwhelmed with treatments and finances. More than half of parents suffer from acute stress disorders after their child's diagnosis. And siblings can experience confusion and fear and resentment as their normal life activities and their parental attentions are completely replaced by a difficult medical journey. Siblings are often unintentionally overlooked as parents struggle to manage the financial and the medical concerns. And this is where Hope Kids steps in and why we exist. Hope Kids' vision is to restore hope and transfer the lives of children with life-threatening medical conditions, their families, and the communities we serve. Life-threatening illnesses bring a host of isolating circumstances that most of us never experience. So Hope Kids provides a unique, supportive, and recreational environment for connection, sharing, and encouragement for the entire family. The Hope Day program brings families together who understands each other's journeys and helps create fun family memories, all offered at no cost for families. Our community of children and their families really get to know each other, to encourage each other and support each other. And our families are in all different stages of their journey. Some of the children are newly diagnosed. Some children are in the midst of very difficult treatments. And we have children now who are also healed and healthy. Once you're part of Hope Kids, you are always a part of Hope Kids. You never age out. And also the unfortunate and very sad reality is some of our Hope Kids will pass away. And we invite the families to stay a part of the Hope Kids community because they've built such a strong connection among families who understands their journey and their struggles. And having the ongoing calendar of free events to choose from is simply not about fun activities. It's about having hope for the future. It's about having an event on the family calendar that doesn't involve visiting the hospital, doesn't involve treatments, and it's about the connection, the community, and family memories that our families desperately need during this difficult time. Here's a quote we received from one of our Hope Kid families. Hope Kids gives an escape from the chaos of cancer. It allows us to take breaks and focus on having fun. Otherwise, we would just be stuck at home or in the hospital in the vortex of sickness. Thank you for allowing us to lift up our heads and see more of the world around us. Our Hope Day program really works to foster a unique community among families who get it. These events are to provide opportunities for families to deepen their relationships and build a strong support network at a time when they need it most. Each month, Hope Kids offers a variety of highly anticipated family events, typically 25 to 30 per month. Over the past year, our events have looked a lot different, especially taking care of our population. We knew we wanted to create that connection, but do so in a safe manner. So we did events virtually, and we would do things through hybrid events, families drive through, pick up things, we meet back together on Zoom, still creating that connection, still keeping those relationships going, still having something to look forward to on the calendar. And again, the events are open to the entire Hope Kids family. If the Hope Kid is not able to attend, the siblings can still go. Sometimes we have events just for parents to come and get together and build that community, whether it's mom's nights or dad's nights. And the majority of our Hope Kids events are private to provide safe environments in smaller atmospheres and limit the number of germs that the families are exposed to. And these family Hope Day events are all designed to allow families to escape the hard moments, financial worries, and provide hope and anticipation for the future. With these Hope Day events, we really focus on 5 research-driven impact areas to ease the journey for families who are walking through the hardest time of their lives. Hope and anticipation, really strive to keep the kids and their families looking forward to the next fun event rather than dwelling on what they're dealing with their present treatment. Family focus, again, the diagnosis not only affects the child, it affects the entire family. So we really learn to serve the whole family and also prevent siblings from being unintentionally overlooked. Community and support. Our events foster lasting friendships and support among people who share similar challenges. And safety and acceptance. We have a very supportive peer community. No child is the only one in a wheelchair or with a trach or has special equipment. No one's looked at differently. At Hope Kids, everyone belongs. And economic support. Again, all of our events and programs are completely free at no cost to the families because we understand that the families are overwhelmed with the medical costs. And then looking at those 5 research-driven impact areas, we had an outside company survey our families to see how we were achieving impact. And this is the results. 93% stated that Hope Kids increased the amount of time that the whole family spends together. 97% stated my Hope Kid has a more positive outlook on the future. 93% reduced families' financial stress. And 98% Hope Kids provides an environment where my Hope Kid is accepted for who they are. This is our 2020 impact, and this is specifically for Hope Kids Kansas City. Again, even during last year and all the challenges, we really wanted to keep that community going, really wanted to keep the events on the calendars for the families to look forward to. And we were able to still offer 383 events in a unique and safe way. And we couldn't do that without amazing event partners and volunteers. We were able to serve 421 families for a total of 6,870 event attendees. Again, as we do believe hope is a powerful medicine, a part of the survey on the impact, again, 97% of Hope Kids family agrees that their Hope Kids provided hope and anticipation for their family, and also provided opportunities that would not be otherwise available due to medically related challenges. And I just want to leave you with one more quote from our families to why we do what we do. Having things to look forward to that are fun and meaningful do make a difference for a child that goes through so many medical challenges. It does change the outcomes of treatment. We've seen quality of life improvements. We've seen medical improvements. Small things over time add up to big things. And the fact that there's something good to look forward to has made a difference for her. We're not promised tomorrow, any of us, but the ability to do things as a family is something that will stick with us and is nothing but pure joy. And that is from the Bynum family. If you'd like more information on Hope Kids, it is at hopekids.org. And now I would like to introduce Andy Elliott, one of our amazing Hope Kids parents, and give her perspective.
Hi, everyone. As I get set up here, I just want to reiterate what Kristen was saying about how impactful Hope Kids has been on our lives as a mother of a medically complex kiddo. It has made differences that I can't even begin to tell you, just in the overall happy and health of our family, from either my Hope kid, my husband and I, or her sibling, and the life that we live with such a burden of medically complex trauma. So I hope everybody can see my slides. I'm going to go ahead and get started. My name is Andy Elliott. Like she said, I am a mother of 3 and a grateful Hope Kids member. And I'm actually also a Beacon Clinic member through Children's Mercy. I'm thrilled to be able to be here speaking with you today about trauma-informed care from a family perspective with an extended medical trauma. My speech today is directed more to the professionals that I interacted with as a mom of a medically complex kiddo, but I hope that no matter where you are and what your business is, that you'll be able to apply some of these applications to the interactions that you're having with families like mine. To tell you a little bit about myself, I'm living a blessed life. I have 3 beautiful daughters, a home in the suburbs, and a husband that's been my best friend for more than 20 years. A couple of years ago, my daughter, Audrey, who was 10 at the time, says, "Mom, I found a lump right under my left nipple. It wasn't there last week. I know that you all know exactly what was happening." Yeah, me too. She had a rare form of pediatric cancer and would be dead in just a few months. Was that the answer that you guys had? No? Just me? Oh, okay. So I smiled at my daughter and I said, "Welcome to womanhood, sweetie. This is just the beginning of many changes ahead." Then, the minute the pediatrician's office opened, I made an appointment to have her checked out. Imagine being the doctor in that room. You've never met us before, and I say something so incredibly out of left field as the obvious breast bud forming in my daughter was a rare form of pediatric cancer. How do you respond to that? What the doctor didn't know was that for the previous 7 years, we had been battling an incredibly difficult and rare disease discovered in my youngest daughter, Charlotte. That caused her to be nonverbal, non-mobile, and mentally at about a 5-month-old level. Of all the chaos the disease caused, the worst was the catastrophic epilepsy. Dozens of seizures per day, sometimes hundreds of seizures per week. Charlotte had no reprieve, and neither did I. Long days and sleepless nights filled with trauma and fear became a nightmare of seizures, treatments, therapies, and advocating for my child. And Audrey had to just come along for the ride. Our family had to adjust to the idea that Charlotte was living on borrowed time. I have watched my child die a million times, never knowing if this is it. Will this be the seizure that doesn't stop? Did I already miss that seizure and she's already gone? My first task every time I woke up, day or night, if I wasn't already hearing a seizure, was to calm my nerves and prepare to find her dead in her bed. This was a grim probability for me. Can you imagine that? Empathize with it, feel it? This was my reality every day for 2,487 days. There's a saying in the medical community that when you hear hoofbeats behind you, don't expect to see a zebra. But Charlotte was a zebra. More than one rare diagnosis and body systems that could do things you would never imagine. My daughter's illness was a menagerie of zebras, and I was their keeper. This changes you in exaggerated ways. Nothing is simple or easy. When I had to meet a new doctor or bring her to the ER, which happens often with medically fragile warriors like mine, I had to start all over from the beginning of her story. It was hard to convince people who were trained to look for horses to look for stripes. I always had to fight. Sometimes I was fighting for her life. Charlotte died from epilepsy in 2019. The seizures eventually took over her brain, and there wasn't space for anything else. It was an impossibly hard season as we had to place her on hospice and plan for losing her. It's a trauma that while I can share it with you, unless you've experienced it, there's no way you can truly empathize. I would like to share with you now some of the trauma of an extended medical crisis. Trauma complication number 1, marital stress. Parents with medically complex kids have an over 30% higher chance of divorce. The stress is daunting. My husband had to work more than a full-time job just so we could survive. The cost of having a special needs kiddo is astronomical. With a child in almost constant state of emergency, my more than full-time job was managing her care. So we had 1 income and 2 full-time jobs. Isolation. This life is so isolating. Families with complex kiddos don't have the support system you think they have. Friends drop off quickly, and that's no surprise. But family leaves you soon after. Our family was so afraid of her death that they weren't there to help her while she was living. Dropping out of school activities, church, and community is inevitable when you don't have that support. Running away. We're often running. I started to notice that families of medically complex kiddos were busier than the lifestyle required. I know firsthand that medical trauma creates an overwhelming helpless feeling and that we need to distract ourselves from it. Home is a really scary place. That's where the heartbreak is. Quiet for us is not restorative, it's dangerous. How do you process or accept something that's so hard to process or accept? Decision fatigue. Extended medical trauma causes all sorts of issues like anxiety and hopelessness. Did you know that some of that stems from decision fatigue? We've learned a lot about this phenomenon during the global pandemic. All of the choices seem so much heavier than they used to. Families like mine have been making life and death decisions like this for years. We are both told that we don't have the medical training that the doctors do, and that we are the specialists of our own children and they will follow our lead. It's 2 different sides, and that is a lot of pressure. So let's talk about how you can help. Often we point out issues, but solutions aren't offered. Here are some actionable ideas from the patient perspective. Don't assume. There's an old adage that says, when you assume, you make an ass out of you and me. When you walk into a room and you see my child and me, don't assume that you know me. We all stereotype and make assumptions. That is an efficient way to process information. But in this case, it's damaging to the flow of positive change. I see the quick assessment of me and sometimes feel discredited, like I'm made to fight for your respect. But spend 15 minutes in a room with me, and I almost always get asked if I'm in the medical field. Your assumptions of me have now changed. And while it's still wrong, for the first time, I'm feeling heard and our conversation seems profitable for both of us. It shouldn't be that hard. Our outward appearance rarely reflects our inward experience. Heard and accepted. We need to feel heard. Our socioeconomic status or perceived intelligence doesn't have anything to do with our disease or diagnosis or our determination to solve our child's problems. I've spent time advocating with families at doctor's appointments and with insurance companies. Families can't easily articulate their needs and don't always know the right words to express their frustration and hopelessness with the system. It rarely has anything to do with their station in life and has everything to do with their level of unyielding stress. Parameters. It is correct that we know our children better than you do. However, we don't know what's safe and what's not. The most helpful tool you can give us are parameters. Call if anything changes is very scary. When my oldest Audrey was born, she'd had a possible high heart rate. So she came home on a heart monitor with the instructions that if she sets off the alarm, calm her down immediately. That was it. I was new to babies and new to medical issues of any kind. Because of the oversensitivity of the equipment, the frequency of that alarm had me so afraid that my baby might spontaneously combust that my first month of being a new mom was the worst thing I'd ever experienced. No one told me that my baby wasn't going to die, that this was just a diagnostic tool. Parameters make all the difference in the world. Very specific if-then instructions gives us some security. If her heart monitor goes off this many times, or her heart rate is this high for this long, take these actions. If this does not occur, you're okay. Parameters give us the ability to feel safe and a knowledge of when to feel concerned. Empathy and reassurance. Empathy, regardless of a person's actions, are so important. When I'm meeting you for the first time, even though I know you're there to help, my experience says, I'll have to fight you first. We are usually going to discuss what is personally traumatic for me, even on my best day. A minefield of triggers are all around me and you can't even see them. Showing me empathy makes it safe for me to be scared and ask questions. Reassure me that while my job is impossible, I'm doing it very well. No one understands our medical complications except maybe you, the doctor. Positive feedback from someone who will help me navigate my own minefield is invaluable. PTSD and residual anxiety. PTSD is a reality for Audrey and always will be. That's what made her breast bud become a scary problem in her mind. She still sees illness where there is none and has a lasting separation anxiety. But you would never know that if you meet her. I'm often a small crack away from falling apart. My trauma has changed me mentally, physically, and emotionally. Among other things, I have an undeniable and exaggerated fear that I will lose my healthy children. My curtness and exaggerated anxiety may be because I know life isn't fair. I know people die, and that while most people never experience a zebra, I've experienced a stampede. So back to my story at the beginning of my talk. Luckily, the day we went to the doctor's office with a simple matter and a complicated fear, she reacted just right. She quickly heard and accepted me and everything I was implying. She gave me parameters to watch out for going forward and when to start feeling concerned. She gave me empathy without even knowing that Audrey's sister had just died a few months before. I never saw that doctor again, but I'm constantly grateful for that one time when a pediatrician helped me turn a zebra back into a horse. Thank you for your time today.
Thank you so much, Kristen and Andy. That was tremendously powerful, and I really appreciate your bravery in sharing your story. It's just really powerful, and you know, our thoughts and prayers continue to be with you, you know, in your family's journey. That was really, really powerful. We have 11 minutes left before our session concludes. So, you know, I would like to open this up to anyone who would like to unmute themselves and ask any questions of any of our speakers. Or I'll look in the chat box here. Hearing none now. But I do think, you know, that was just, I think, a wonderful experience. I think hearing from all these different stakeholders, I think is just a really powerful way in which we can hear different healthcare topics in our region. I think hearing from, you know, the organizations in our community that can support these families, from a family who's been through it, from healthcare providers who are providing this type of care, really powerful. And then from the researchers and nonprofit organizations who are also providing their services. I think, this is something we all know is real and pressing in our community and around the nation and around the world. So kind of trying to come together and figure out solutions is always wonderful, or ways we can help these individuals and families. I'm reading the chat. I don't see any more questions. It does sound a little silent, but if that's so the case, please do just all know that we do record these sessions and they are available on our website, and early next week they'll be available. So you can certainly go to our website. I think there's a link in the chat for that. And also know these are monthly forums and you can register for these on our website, and reach out to us if you have any questions at all. But with that, I guess I'll give everyone a few minutes back of their day, and thank you again to all of our speakers and to all of our participants for attending.